Okay.
So today it's my pleasure to introduce Dr. George Ford. He's one of two pediatric endocrinologists and the head of the Department of Pediatric Endocrinology here at ETSU. Dr. Ford joined us in 2015 out of fellowship at Oregon Health and Science University in Portland. Prior to that, he did pediatric residency at Dartmouth, and before then was in medical school at the University of Washington. So today he's going to talk to us about a topic that I'm sure comes up all the time and does in my practice, pediatric obesity.
Okay, great. I tried to create a much shorter version of my discussion of this topic that will actually fit within the time we have. Basically, what we're going to go over today is a little bit of pathophysiology, kind of a typical case that you'll see in a primary care center, or that's often kind of referred sometimes for us to see. Along the way, if you have questions about management or what to do or not do, feel free to chime in. I try to go over a little bit of do's and don'ts along the way. There's some things that people do fairly commonly that really aren't that helpful. And then, again, kind of just open discussion as we go along. My goal isn't to finish every PowerPoint slide, it's to make sure we're having a good discussion. So with that. I think we kind of have the basics here in terms of glucose balance. We need good insulin secretion, and then second feature, very important for type 2 diabetes, is the insulin action, and the loss of this balance causes a problem. And in type 2 diabetes, we're dealing with that insulin resistance as the issue compared to type 1 with the autoimmune destruction of those cells. Most of these kinds of issues are acquired. People are typically overweight or obese, often sedentary. We've got a little kid here playing their 4 hours of video games. Some medications, especially antipsychotics and others, can really cause weight problems, and I'm sure you've seen that. And then, of course, we have rare kind of inherited causes. Those kind of causes should be thought about if the child is less than 5 and there's not a good story for exogenous obesity. And I have a whole talk on that, but couldn't really include it with the time I have. So maybe I'll do that talk another time. This is just a kind of a cross-section kind of showing what happens as visceral fat increases, especially in the abdomen, and resultant increase in insulin resistance. And this is kind of just showing what the pancreas should normally do when insulin is released. So you kind of have that first phase there that you'll see, which happens when we first start eating. Our body actually starts secreting insulin even before we start eating, as it anticipates food coming. You'll see that peak there on the first phase, followed by kind of a lull, and then kind of, again, a general increase after that to keep the blood sugar within a normal range. And here's kind of a chart which shows what happens in type 2 diabetes. And if you look here on the left, you'll see a normal graph. On the right, you'll see type 2 diabetes. So again, on the normal graph, you're going to see that natural, very significant rise in insulin right as you're starting to eat, followed by kind of a taper. Where in type 2 diabetes, you can see that phase 1 becomes blunted, and you basically are only left with a fairly weak and often inadequate second phase. So that's kind of how that insulin resistance begins. So kind of what are the warning signs? The first thing is after eating, or postprandial sugars are going to start to rise first because of the loss of the first response. The resistance increases both kind of hepatic and peripheral. And then over time, fasting glucoses begin to rise as well. So if your patients got to that point, they've gone well beyond losing that first response. And then once those blood sugars are significantly over normal, hyperglycemia to some degree is actually toxic to the beta cell itself. So you actually, in type 2 diabetes, do to some degree begin to lose some of your beta cell function. It's not quite like type 1, but you can kind of almost end up in between. And then, of course, as insulin level falls, blood sugars continue to rise. So how many of these patients are we kind of talking about? In the Haynes study, they found that just a little under 12% of adolescents were obese. Tennessee, in a 2012 study, fared worse than that. And last I looked, we're 5th in the country for obesity. But adolescents were 16.1% were overweight and 15.8% were obese, so a total of almost a third of all adolescents in Tennessee. For some reason, Virginia did not do CDC statistics on that at that same period. There was, I guess, just they wrote insufficient participation, but I would suspect that rates are similar to Tennessee. And in one study called the Stop with 2 Ps type 2 diabetes study, they did find that adolescents who are overweight or obese, 40.5% of them had impaired fasting glucose. So kind of concerning. This is kind of just our basic review slide of type 1 versus type 2. The only problem with this slide is approximately a third of patients with type 1 diabetes now present being overweight and obese. And so the picture is kind of muddied compared to the way it used to be. But you are looking for that acanthosis nigricans on the neck, axilla, and groin area. Certainly higher risk if they're not Caucasian, teenagers, and then normal to elevated insulin levels are there. So this is a common question. Should I get an insulin level? My answer is no, for a number of reasons. One is often the insulin levels are drawn and the family has not actually fasted, or they get it at a non-fasting period. So if they've eaten food, all we've proven is they make insulin when they eat. And I would say that most insulin levels I receive, that's the case. The second thing is, what are we going to do with that? If they have acanthosis and other kind of warning signs for diabetes, knowing their insulin level is not really helpful or useful. It does not change management, either for the PCP or a pediatric endocrinologist. So the only time I really get insulin levels or a C-peptide level is when I'm not sure if I'm dealing with type 1 or type 2 diabetes and the picture is opaque and unclear. In those instances, that is helpful. So other than that, I don't recommend insulin levels, and also the official recommendations for the management of exogenous obesity don't recommend them either. And then you can get some ketoacidosis in type 2 as well, so that also can kind of muddy the picture between type 1 and type 2, about 25%. And we kind of went over this, but you know, we do want to try to distinguish the two. The other thing you would send if you're not sure between the two is to send anti-GAD and anti-insulin antibodies, along with that insulin and C-peptide. You know, if they're less than 10, the statistics are that's very, very rare for type 2 diabetes, even for pre-diabetes, although I will say I have met people in Tennessee as young as 9 who have diabetes and actually had all the complications of diabetes. So even though that's kind of the rule of thumb, sometimes it does not hold for our area. Another thing that's very useful is just kind of watching what happens when some form of treatment is started. Type 1 kids are always going to kind of go through a period of honeymooning, whereas type 2 will not, and they'll often have much higher insulin needs. Again, this kind of goes back to some things I was saying before about the differences. I think I've kind of said this slide, so I'm not going to dwell on it. So here is just kind of the basic criteria. I think most people know this criteria. But once you have an A1C 5.7 to 6.4, you are in the pre-diabetic area. If someone has an A1C that's still normal and you're just working on lifestyle modification, that's usually something that does not need to be referred to a pediatric endocrinologist unless you feel that there may be a genetic or other component that's being missed, and you don't think it's the most common form of obesity, or which is exogenous. It's actually kind of rare for us to diagnose someone with type 2 diabetes in childhood. We have quite a number of people in the pre-diabetic range, but if they're managed and we're trying to help them and potentially putting them on metformin, a lot of them don't graduate to true diabetes until their 20s or 30s. Although, as I mentioned earlier, there are exceptions. Certainly, if you're seeing fasting blood sugars over 126, that's diabetes, and certainly an oral glucose tolerance test with values over 200 would be diabetes. So it's just kind of basic review. So there are guidelines from the ADA regarding obesity. They do recommend that PCP screen at least every 3 years from age 10 onward, and again, less than 10 because it's just so unlikely, is not necessarily screened. Certainly any BMI greater than 85th percentile for age and sex or weight, or greater than 120% of ideal for height. And then the other time to be screening is if they have 2 or more risk factors, so positive family history of type 2 diabetes, if mom had gestational diabetes, especially if it was during the child's gestation, if that child is at higher risk from the mom having gestational diabetes. All the other signs, including some that I didn't mention, but dyslipidemia, hypertension, PCOS. Also, small for gestational age infants tend to have more issues. And then, of course, we have our high-risk groups. We don't have these groups as often here in the South, but we do have some of those patients there listed, the high-risk groups. I have a couple Native Americans that every single person in the family has type 2 diabetes. Well, before I go to the case, any questions from the audience?
I have a question.
Sure.
In terms of screening, I know sometimes insurance has issues with ordering A1Cs. At least I've run into that in the past. A1C is the preferred screening test, right?
It has become the preferred screening test. Like any test, it has advantages and disadvantages. But it is the primary screening method. It is usually the most helpful and informative. Usually you can get it covered. It can't be run more than every 3 months for most insurance programs. So if it's been done in the previous 3 months, you wouldn't want to because they'll get charged for it. But we tend to not have problems with that. I'm not sure if that's the same experience for PCPs. Anyone having problems?
Yeah. I can tell you it depends on the code you use.
Okay.
We found that a BMI code doesn't fly, but if you use overweight or obese, then it flies just fine. So you have to be a little cautious about the code.
Well,
thanks. Yeah, I've also found that documenting at risk for type 2 diabetes or acanthosis nigricans also seems to work out fine.
Yeah, right. A finding like that will get you there.
Yeah.
The strictest coding.
Right. Yeah, so I do think it's often just, again, secret words of coding, which have nothing to do with medicine, but allow us to get things done for our patients. This is kind of a case that's fairly typical, and I've kind of borrowed from a case that came to our clinic. So we had an 11-year-old female who was referred for morbid obesity, kind of had that very typical high sugary beverage content, soda, juice, sweet tea, actually endorsed drinking 1.5 gallons of sweet tea per day. which mom thought was actually an under-reporting. She said it was closer to 2. When I go over their basic foods, they usually have some sort of fried food or a hot pocket or something like that for breakfast. Pizza and hamburger or tacos were the go-to for pretty much every lunch, with pizza being the number 1. And then pizza appeared again at dinner, along with their favorite beans, cheese, and chips. Not a lot of diversity in the kids' diet, not much of a vegetable eater. We'll eat grapes, but which is one of the highest sugar fruits you can eat. And then activity, not a lot, although she does say she walks to and from school, and mom and dad thinks that's at least 1.5 each way, so 3 miles. I should say 3 miles on average for the whole week. Other than that, no interest in sports or activity. They like YouTube. There we go. Kind of past medical history, is having some depression, does endorse kind of this chronic constipation, ADHD, family complains of a lot of fatigue and mood swings and anxiety and not sleeping well, has had a TNA, does have, as you can see, 3 family members there with type 2 diabetes. Also, we're getting kind of a metabolic syndrome picture here with the hyperlipidemia, high blood pressure, and obesity in multiple family members. The patient lives with her dad in a trailer. Mom is not involved due to severe mental health issues, and I do believe she was in and out of the prison system as well. Dad is not employed at this time, so he reports they really don't have the money for healthy foods, and their go-to for everything is either frozen foods or fast food. Kind of looking at this, we've got a weight of 96.5 kilograms, well above the 99th percentile. BMI that's now 38.9. We've got some hypertension going on with a 143 over 81. Heart rate's normal. Height's 87th percentile, which is probably driven to some degree by overnutrition. And in this case, their A1C is in that pre-diabetic range at 5.9 in office. They have very pronounced acanthosis nigricans, very visible. Family actually complains that they had tried to scrape it off with soap and other kind of sponges because they thought it was dirt. So we told them not to do that anymore. She's otherwise normal appearing. Her obesity didn't start till her kind of late tweens and early now teens. So no kind of history that would suggest some other problem that started from infancy. She's also tanner to breast and pubic hair. Otherwise, exam was unremarkable. So we get our initial labs on this patient in clinic, and notably, they have a elevated microalbumin to creatinine ratio, as well as a second specimen that was performed 3 months later that was very, very elevated. This whole slide is trying to highlight the fact that people with pre-diabetes that's been basically completely ignored in terms of diet, exercise, or any other treatment are at risk for having all these problems from the onset. This is very different from type 1 diabetes, where that would be very much unexpected and usually happens much later in life, and only usually if people are ignoring their glycemic control. Type 2 diabetes is not a friendly disease. So we do meet children who already have a lot of the problems. You can see the LDL here is 120, and cholesterol was 210. Triglycerides were 190, and this is a fasting sample. And then you can see that good cholesterol is also tanking at 22, probably a reflection of both inheritance and sedentary lifestyle. And then on our CMP, we've got that typical signs of some transaminitis going on. We often get that range kind of in the 50s to 60s. She actually had one up into the 90s as well. So then we have to worry about an AFLD because there's so many other things that can cause problems with the liver and fatty liver disease that really does need to be confirmed by a GI doctor. So if you're finding significant persistent transaminitis, they really should be seen by GI to ensure it's not another cause. We have occasionally found patients who had a different cause for that problem, unrelated to our presumption that it was related to their obesity. One thing that was nice is their thyroids were normal. Everyone always thinks it's the thyroid that got them overweight. Very rare. And then vitamin D is often low in most of the population here in Tennessee. But certainly someone who's not getting outside or playing, very common. So again, we've got all these comorbid conditions. What do we do about them? So for hypertension, you can start with lifestyle modification, try to reduce salt in diet. There's various studies trying to look at salt and its effect. The overall consensus seems to be that about 50% of people are truly salt sensitive, and reducing salt dramatically changes their blood pressure, whereas another 50% doesn't seem to do much of anything. If you can kind of show that they have hypertension on 3 occasions over at least 6 months, and despite lifestyle management, you're still struggling, you can consider starting an ACE. I would try to confirm those blood pressures are not white coat hypertension, so you'd want to collect I often have patients make a journal of blood pressures from home, or they get them when they're at the store from one of those automatic cuffs. So I could at least get a sense of what does the blood pressure actually run. For type 2 diabetes, there's also a lower threshold for the goal for the blood pressure, less than 120/80. So that can be hard to actually, excuse me, that can be hard to achieve. But those are the times where you might think about doing something like that. Again, with the transaminitis, I kind of already touched on why we need to potentially, if that's persistent over time, and certainly if it's worsening over time, I would recommend Pete's GI, ensure it's not something else. Obviously, as all these things combine together, we've got metabolic syndrome, which increases our risks for atherosclerosis, early heart disease, and renal complications. So kind of going to cholesterol and obesity, the most common pattern we see and was kind of manifested for her as well is this very low HDL with a high triglyceride even when fasting. And so again, we're trying to reduce intake of carbohydrates, saturated fat, simple sugars. If triglycerides are over 500, the recommendation is to treat with a fibrate or niacin. I've never used niacin myself. This is, of course, to help reduce risk of acute pancreatitis. Excuse me, I'm starting to get a little parched. And then, when would you consider a statin in these patients? Again, you try at least 6 months of lifestyle modifications. If LDL is greater 130 or LDL is greater 100 plus a cardiovascular risk factor, you would consider starting treatment. You'd want to know that their liver function is okay, which may not be, before you start treatment, because it can cause additional transaminitis. Usually puts it about 3 times out of the normal range. So if someone's already has transaminitis, that's another reason why you'd have to get it through GI first to make sure they don't think anything else is going on. And then you'd have to try to use whatever their baseline is and make sure that it's not increasing on the statin. As most people know, the most common side effects are myalgia, if they have that, you check a creatinine phosphokinase. And then, you know, what is a statin going to accomplish? Well, it's mostly going to reduce bad cholesterol. It's going to cause a modest increase in good cholesterol and some decrease in triglycerides, but really a statin really isn't going to be that successful if we're not making some efforts at lifestyle change. Any questions on statins, hypertension, transaminitis?
So for a patient who's female entering adolescence like this, do you have any stipulations on birth control if you're going to start an ACE inhibitor?
Usually my mantra is if you're going to start it, we want to start an oral contraceptive pill at the same time. You do want to make sure that they understand that these are teratogenic, that they, we don't want you to be pregnant on these medications. Sometimes families are resistant and insistent that their child is not interested in those activities. So in those cases, our hands are a little bit tied and we've given them their benefit risk analysis. But my general thing is I just tell families, because we want to ensure that no pregnancy occurs, I recommend starting both. Do other people find that that's the case for themselves for when you use ACE inhibitors?
Absolutely, that's our protocol. I mean, we pretty much do our best to have them on contraceptives. We trend more to, of course, LARCs or Depo-Provera when possible because of the inconsistent use. But other than that, we feel pretty strongly that we try to advocate for contraceptive if we need to do that.
Okay, good. And those are good examples of things that, especially for patients where you think they're not going to actually be good at taking it. But then you have to wonder how often are they going to take the ACE inhibitor, right? And that's often my problem with a lot of these medications is, I can try to put people on a statin or I can try to put them on an ACE inhibitor, but adherence is often a problem because, if we're not making any strides in lifestyle modification, are they really going to take a pill every day? And so, that's just a challenge of providing care to a bunch of teenagers. Adults aren't much better, I guess, but it's a problem. So anyway, again, that's kind of where you're going to think about your statins. Certainly, there's no way pediatric endocrinologists can see all the obesity in the region by any stretch. So we do want people to feel empowered to make some of these modifications. Our clinic does have the advantage now that we have a nutritionist. So one of the advantages in our clinic is we can kind of evaluate for all these things, follow for possible intervention, and also have them start meeting with the nutritionist in office. So that is helpful, but again, impractical for us to see people. Generally, if someone hasn't got an A1C that's reached the pre-diabetic range, there's not a lot of reasons, unless there's some compelling things going on, to refer at that point. Because in general, we're just not able to handle those referrals because there's just too many of them. So another case, which in this case, this patient had 2 specimens over several months that showed microalbuminuria. So we did start lisinopril in this patient. And also, of course, they had the hypertension. So we were kind of going for a double, two things with, what am I trying to say? Something with 2 stones. That one. That's a 2 birds with 1 stone. But the blood pressure in this patient actually did come down quite well once we started lisinopril. And I think once the dad realized how badly all these things, like when they saw all the complications coming back, the family really did start taking it seriously. And the patient did start making some strides in terms of weight loss and diet changes. We did try to also screen for retinopathy, but the patient never showed up to any of the appointments, but certainly would have been at risk for that. In the case, she did complain quite a bit about poor sleep. So you always kind of worry to some degree about sleep apnea and consider sleep study. Um, Psychosocial concerns come up a lot. Bullying is very common, um, especially of girls. But I've noticed an uptick in boys as well recently, where they're really, really bullied, especially if the fat tissue has caused them to develop kind of what look like breasts. Um, that can cause significant anxiety for boys. So kind of this case summary, and this patient's A1C max ended up being just below the threshold for true diabetes as we followed her up to 6.2. But it kind of is an interesting tale because when you read through the literature, not only would they say that this kid just barely over 10 would have a very low risk of having prediabetes or diabetes, but they would also suggest that it'd be very rare to have these complications. But we actually meet a fair number of people once you reach the mid-level criteria by A1C for prediabetes and above that actually have a combination of many of these complications already. So it's something to really keep in mind and screen for, and begin treatment when they meet criteria. So any questions about the case?
You may be covering this later, but when would you start something like metformin?
It is a good question, and I am going to cover that
Sorry.
because it's a very common question, and I do want folks that kind of have a good sense of when to start it. Certainly, once again, people often come to us, and we kind of go through certain steps and then start metformin. But we would like pediatricians and others to feel more comfortable with it as well. So again, of course, you're going to start with your lifestyle modifications. I actually had like many slides about this topic that are no longer part of this particularly short version of this presentation. But your basic goals are often ones we see from the ADA and also from the AAP. But reducing those liquid calories is always a big thing. Some kids, it's immediate change when we've eliminated the sugary beverages they're drinking in excess. Trying to not eat out as frequently. Very common that most people are eating out 3 to 4 times a week, not more. Trying to reduce those portion sizes. And then the other big thing is, of course, trying to battle modern living, which everyone's glued to their screens, whether it's their phone or their tablet or their TV or whatever. So trying to reduce that sedentary time, as everyone knows, trying to get no more than 2 hours of screen time a day. Less is better than 2 even. And then trying to make some realistic goals. When people come to our clinic, we kind of walk them through goals. We talk about several areas of kind of specific dietary modifications. We talk about foods to be buying in appropriate portion sizes from the grocery store. And then we go through various kind of how to set goals for exercise. And then finally, we have a whole section on how to help parents help their kids succeed and create positive reinforcements and goals. So we do have a pretty systematic way we go about that, as well as working with a nutritionist in our office. So, metformin. What to do if lifestyle modification is not working, which, as if you read through the literature, it commonly fails. So really the first time you should really think about metformin is, the most obvious time would be someone has reached the pre-diabetic range. You've tried lifestyle modification. Usually the recommendation is at least 6 months of attempting that, and they're failing. And the way you know they're failing is their A1C is still pre-diabetic range or it's increasing. If someone is not in the pre-diabetic range, we usually do not start metformin unless the family really wants to use it as an adjunct to what they're doing. And usually it's in families where we're finding that A1C is just getting that much closer, and it's hit 5.6, and we're just almost in the pre-diabetic range, and we're just like, oh, okay, let's maybe add some metformin to this mix. What are the benefits of metformin? You're going to increase that insulin sensitivity, especially in those peripheral tissues. And if you're actually doing lifestyle changes at the same time, metformin can lead to modest weight loss. It's not a lot, like 1 to 2 pounds a month-ish. But it can be an adjunct to helping maintain a healthier weight. So the other question we get a lot is, well, how much metformin do I give? I don't know. So the biggest thing we worry about, of course, with metformin is, about 15% or so of patients are going to get GI side effects. And most patients are going to have some initial GI side effects, for sure. But if they kind of stick it out, that often self-resolves. But some people will have persistent in their dose. They just have to be on a lower dose or extended release. As people know, most insurances will not let you start with extended release. So you have to start with the standard treatment. Titrating up to about 2,000 a day is kind of what we do for a lot of patients, as long as they're tolerating it okay. So we kind of follow this regimen here of just kind of slowly titrating it up over 4 weeks. And usually, if side effects are really, say, week 3, we're starting to see a lot of side effects, we know maybe we need to back off a little bit and go back to the last tolerated dose of the metformin. We certainly have patients who fail metformin altogether, in the sense that they just never really get over the side effects, and we can't really maintain a dose that's going to be therapeutic in any way. So then, in those cases, we do prior auth to try to get people on metformin extended release. And usually, if you've documented very well in your note that they have failed treatment with metformin and why, that approval can be received. But it, like so many things in medicine, it's a time-consuming thing to do that. But this is kind of what we want pediatricians to be doing in terms of just slowly integrating it. Certainly, if you're just kind of in that very early pre-diabetic range, you might just start with getting up to 1,000 a day and see how they respond. Certainly in cases where you've got morbid obesity, very concerning prediabetes, nalthacanthosis, or other things, contextual features about the case, you might be more inclined to get aggressive right from the beginning. But certainly, a lot of our patients tolerate at least 1,500 to 2,000 a day without any difficulty. Again, there is a little bit of a transitionary phase in the very beginning where they may have a little bit of loose stool or diarrhea, but then as they continue on, they do okay. So as long as it's not too bad, I often ask people to at least stick it out a week or so before we reduce the dose. Any questions about metformin? That's kind of the end in terms of things. Questions about obesity or?
But I have a texted question.
Okay.
So if you start an ACE inhibitor patient, say they're intolerant, they have a cough or other side effect, where would you move after that?
That's a good question. So then you're having to look at a lot of different features of what's going on. The real answer is there's not a lot of good options in kids at that point, at least not that have been studied. You're basically, you could use other blood pressure medications, but you'd be off-label. You could consider a beta blocker, but so many kids have asthma or other things. The truth is, we rarely, it's very rare to have someone fail both. There's a higher failure rate with the lisinopril for sure, but if you're going to an ARB as a secondary thing, often they do okay on the ARB. So I'm trying to think of if I've had any patient I've had to switch to an off-label. Not here at East Tennessee anyway. In fellowship I did, but and then usually we did that in consultation with cardiology just to make sure we were doing the right thing. But most people were able to find one or the other that works. Our biggest problem really isn't that it doesn't work, it's that people don't take it. And so then obviously it doesn't work.
Sure.
So, you know, a lot of, I mean, I'm sure this is true for pediatricians in the community. A lot of what you're doing is psychosocial and it's motivational interviewing and trying to also help parents really understand why certain things are important to do and try to empower parents so they really understand what's going on. You know, one of the advantages is, you know, when we see patients in our clinic, we're not quite on the same see patients every 10, 15 minutes program that's often common in pediatrics. We are able to spend more time on all these topics. So we do, you know, if you've got someone with prediabetes, it's showing certainly someone that's starting to have complications from prediabetes. We do love to see those patients whenever possible. But we do, at this point, we have had to screen the referrals we get. And again, if someone isn't having complications or A1Cs in the pre-diabetic range, we're usually going to say, kind of give you some advice and kick it back to the PCP just out of necessity in terms of volumes. You know, again, one of the most common referrals we get is patient has a high insulin level. It's not really a diagnosis, and it's like I kind of talked about earlier, it's not really that helpful unless you're trying to figure out type 1 versus type 2. If they're obese and they have acanthosis, then they have high insulin levels. So you already know from your history and exam what's going on. So it's not really, you're just kind of confirming what you know. But I will say the most common referral is high insulin level. Now, certainly if they were like off the charts and we thought something was pathologic going on, that's a different story. But again, the biggest problem is a lot of those insulin levels occur non-fasting. And so they'll get a really high level and then they come to see me and I'm like, well, I see you got this at 2 o'clock in the afternoon and they'll be, oh yeah. And I'm like, what did you have for lunch? And oh, I had a Slurpee and this and that. I'm like, oh yeah, well that's going to give you a insulin level over 100. So again, if you are going to measure an insulin level, make sure it's fasting and preferably in the morning, because otherwise most patients don't really understand that eating all those crackers and cheese beforehand will affect that value. You know, A1C is going to be your most valuable test in terms of trying to tier people. And yeah, those are kind of the basics there. You know, the real sad story of obesity in children, to me, is that we have very little, besides treating complications like we've talked about with statins, ACEs, and others, using metformin, we really don't have much else in our armamentarium besides just insulin for those who reach that point where they actually need insulin as an intervention. It's not common for kids to reach that point, but we do have, especially like Native Americans and others who already were very high risk, we do have those patients on insulin. Certainly if metformin is failing and someone's getting into the diabetic range for their A1Cs, or they're having blood sugars over 200 fairly consistently, that should be a referral because that patient probably needs to be started on insulin, because metformin's never going to get them there. You know, a lot of the other medications used for type 2 diabetes in adults, a lot of them have multiple issues and potential side effects that haven't been studied in children very well. A lot of the studies, you know, their youngest participants are 16 or 18. So kind of limiting in terms of what we can actually do pharmacologically with obesity. So we're kind of left with things that are generally only semi-successul, which is lifestyle modification, metformin, and treating complications with those other medications we discussed.
I have a question about whenever So if I had an adult patient with type 2 diabetes who had failed metformin, failed, glyburide, or a lot of the other, I guess, second line agents, and I were thinking of starting insulin, I'd start monotherapy with like a long-acting insulin, like Lantus. So I wouldn't cover meals. Do you do that with kids or for type 2?
Well, we would look at the overall picture of what's happening with the blood sugars. Type 2 actually usually loses, well, by that point it may not matter, but like we talked about earlier, you're first going to lose your postprandials and then lose your fasting. And if you've got to the point where you're getting high fasting levels, that should be a big red flag. That we've moved into kind of the full-blown kind of type 2 diabetes picture. Which insulin we decide to use, basal plus fast-acting, is a little bit contextual. First, analysis of those sugars. Second, kind of almost a secondary analysis of the family structure and ability to implement a plan. Can we get this family to start counting carbs and covering? The most common thing we would do is introduce a sliding scale of insulin for meals if they're having the postprandial highs. Very commonly, if they're having fasting highs, we would add Lantus. Lantus is preferred over the others, although Basaglar is essentially the same thing. So those two are very interchangeable. Feel free to use one or the other. Levemir, I would try to stay away from. It often has to be dosed twice a day to be effective, and it has a much higher rate of hypoglycemia in children. I avoid Levemir. I got rid of it at the hospital, at least on the children's side anyway. They still use it on the adult side. And it does actually seem to work better in adults. And in some adults with type 2, it seems to work pretty good. But I just have not had that success translate over with children. And then, the other thing is, to some degree, you have to be a little careful with what you're eating. It's almost a little safer to add that sliding scale to start, because kind of cover some meals, they're awake. If they're still kind of in that earlier stage of type 2 diabetes, their insulin resistance and insulin release is going to be variable. So if you add Lantus, you could bottom them out some days during the week, especially if they're younger. So those are kind of some thoughts there on insulin. Any questions on that from anybody? I mean, the one thing I will say is, if someone needs insulin, they probably should be meeting with a pediatric endocrinologist. Yeah. Just because in terms of supplies, consideration for continuous glucose monitor, consideration for switch to an insulin pump, and all the other components of that, it is helpful to have that part of the team involved. And those would be our most preferred referrals, because there's a very clear necessity. Whereas a lot of the other things I have kind of in my slideshow, we really want to empower our local specialists and everyone else to be able to feel comfortable with starting to use those interventions and screen for them, and because we're fully aware that we're never going to meet the need. I think as primary care physicians and others feel comfortable with these interventions and metformin and other things, it's very helpful, because then also they know kind of that threshold to refer.
And I have one other question.
Yeah, it's a question.
Yeah. Dr. Wallace?
Yeah, no, I was going to be a comment to really support what you're saying about continuing to train the primary care force, because truthfully, the interventions in at-risk children and those that are already obese is going to be in the primary care setting. I mean, you'll see them maybe, but if we're really going to make changes, it is going to have to be at the point of care in primary care. So one thing, and I don't have the results to tell you yet because we're not through with the study, but we're working on an NIH grant on targeted interventions that can be done within primary care for at-risk and obese children to see, we're in an integrated care system where we have behavioral health consultants in our primary care. So I think it's going to be these kind of interventions that hopefully can complement so that we don't have to send people to you. But, primary care still does not feel that they can do as much as we can because they feel overwhelmed. And but if we can break it down into pieces that we can manage and make small changes, because let's face it, you counsel extensively, and that's exactly what people in your setting need. But just like if I give a patient a cancer diagnosis, they hear the first thing I say and then it's all gone. So we need to continue these conversations so that we can really improve the care and hopefully send fewer patients to you. I don't want to run you out of business, but you want to see those that really need your expertise, and we can, I think, continue to do more within our arena to help hopefully change this obesity epidemic that we're seeing.
I totally agree. And we have plenty of business without obesity. Certainly at those intervals we discussed where okay, additional interventions are needed, a more intense look at insulin or other interventions. We'd love to see these patients. We want to help them for sure. But if we're really going to make any kind of meaningful dent in obesity and its related complications, it will absolutely not come from pediatric endocrinology. I think there's 1,000, just a little over 1,000 pediatric endocrinologists in the whole country. So that definitely is not going to have any, if anyone does a study, there will be no significant change in complications from obesity related to pediatric endocrinology. It's just not going to happen, at least not as a group. Now, individuals, we certainly do find we're able to help a lot of people make some big changes. And we love those cases. And just like PCPs, we also have the same experience where all efforts on our part seem to not bear any fruit.
I think we've reached the end of our time here. Dr. Wallace, were you able to log in for the CME?
Yeah, I haven't done it yet, but I haven't tried it, but I usually can get in. I usually do it after. I'll take care of it.
Need to hold up the QR code to the camera here. But thank you for joining us.
Yeah, thanks for joining us.
It's nice to meet you.
Look forward to the results of your study.
Yeah.
Yeah, we'll share with you when we get the results of it. Thanks so much.
Okay, yeah, thanks.